Next lecture is on retrograde technique by Dr. Kirti Punamia, and he is known for his work on CTO, and he has lectured, and then he is going to show us some case examples. Dr. Punamia.
Good afternoon. Thank you, Dr. Rath and Raghu, and again, I thank Dr. Srinivas Kumar for giving me this podium space and time. What I'm going to do is in the next few minutes try to elaborate from my own experiences of where we have and how we've kind of developed, how we've kind of progressed in our own retrograde approach in our program. Our experience comes from 2009, 2010 onwards. We've attempted 35 retrograde cases, 20 of them in the right coronary artery, 15 on the LAD. We've failed in 2 cases in the LAD, 1 in the RCA. We've had one death after we completed the procedure. We've had a death in the first 48 hours from a perforated duodenal ulcer with massive hemorrhage and aspiration of heme. We got to start off by saying that it's time consuming and it's resource consuming. We have to have the patience to deliver, we have to have the gentleness to approach these coronary arteries, and we have the humility to stop when you need to so that we don't endanger patients in pursuing this procedure. The vital steps that we have are setting up the angiography, and that has been shown amply by various operators in this meeting, and that's the occluded artery as well as the donor artery. Collateral channel crossing is the next step, and assessment and selection of channels, selection of wires, and crossing the channel is important. Once we cross the channel, we wire the CTO antigradely or retrogradely, or both in most cases with the hybrid approach, and then we connect these wires using either the cart, a reverse cart, or a retrograde star. It's important to then externalize the retrograde wire and then have an antigrade access either over the same retrograde wire or an additional antigrade access with an additional wire, and then complete the case. And it's very important to exit and complete without complicating yourselves at any stage. Setting up the angiography is of prime importance because this is what is going to give you, because what we have today is technology based on vision here, but most of our CTO attempts antigradely are still blind. Whether we do parallel wire or we do any technology, we are blindly accessing a CTO body and assuming that we are going to be within the intimal spaces. Selection of guides are important. 8 and 7 Frenches always. A 90 centimeter guide will help in a particularly tall patient to make sure that your Corsairs and microcatheters do not run out of length. Never lose sight of the donor guide while you're doing and performing the retrograde. Simultaneous retrograde angiography estimates the true length of the lesion, helps you kind of plan the procedure to the most part. Selecting the angiography study channels. I've used aspiration catheters like the Diver Thrombuster or an export catheter into the distal donor artery and then make a selective injection just prior to the channels so that I kind of take away the clutter of arteries which are going to confuse me with those arteries. And here is an example where we've used a microcatheter in this particular case. It's important to study the takeoff angles of these arteries, the tortuosity, the visibility of these channels to see if they're visible or invisible, because some invisible channels may exist, and then you've got to make your wire choices based on those visibility images. This is typically done using a 2 cc syringe, and I inject in these channels only if you can get a back bleed. Don't inject if you don't have a back bleed because you're likely to dissect the channels and you're likely to dissect the arteries. It's important then to study these channels, and detailing these channels are important, and once you've got a Corsair catheter into the channel, it's important to take off your wire and make a vision of those collateral channels, because within the channels you'll see sub-branches which might be favorable, and the favorability depends on these things that I'm going to talk to you about next. So what does this tell me? This tells me that the takeoff angle, now When you surf channels, we have this angle, and we're looking for a gentle angle which is more than 90 degrees so that you have a free access into that channel as you approach. So the takeoff angle of the channel is important. Its proximal location is important because if you go into distal channels, the more you travel, the more likely you're engaging the donor artery, in which case you're going to increase your complication rates. Not only that, we look at tortuosity of these angles, and sometimes if there are more than 90-degree bends in these angles and they're making them tortuous, these tortuosities will decide what kind of wire you're going to take. Visibility and tortuosity can be compounded by corkscrew appearance, and this corkscrew keeps expanding, and with the systolic motion of the septum, you will see that the corkscrew increases, and if you try to engage these channels with unfavorable wires, you can cause septal hematomas and dissections. Visibility of the channel is important because if you have invisible channels, then you choose wires which will help you pass those invisible channels, and sometimes you may need to dilate these channels. Approach to the occluded artery of the channel is important, as I see in this particular case that we did a year and a half ago. We found that all the channels that would connect us to the distally occluded artery faced antegradely into the occluded artery. What this does is it gets your wire antegradely, and you are unable to deflect the wire retrogradely. That's where you want to go. And so it's important to study the channel as to how it approaches into the occluded artery as well, and that's important. Once we've studied the channel, we've got all the information, we've dissected it. Through the course of the meeting, I've seen ample of presentations which talked about catheters, the fine cross catheter, the microcatheter, the Corsair catheter, and of course, we have the newer Sortanos and the other microcatheters which will help you have flexibility, and our talk is not going to go into that, but I think this has been well discussed. It's important to surf the channel, and sometimes you may need to surf the channel, and you've got to do the surfing in a systematic fashion. So in my practice, how I surf the channel is I will start with the most proximal septal and then go distally if I'm there, and give it enough time and make sure that I don't do damage to these septals as I go along. And sometimes these septal surfing will get you one particular channel that will favorably get you into the distal part of the occluded artery, and then you can set it up as your collateral channel. Crossing a septal channel is important, and if you look at the image to the left, you can see that in this particular image, you would agree that any of the wires would go up this channel, and a whisper, MS, a Sion, or a feeler XT, you pick any of those, and every of those wires is going to cross this channel. When you get on the image to the right, you can see that the image to the left over here is tortuous. And for these kind of visible tortuous channels, I'd rather take a Sion. We tried to use the Sion blue, but the silicone coating, at least I found it a little difficult to handle, so we've gone back to Sion in that group of patients. And here, in these kind of channels where you have visible and invisible portions of the channel, I still go by the Fielder XT. My Japanese friends tell me that they use the Fielder XTR in this, but we just don't have the Fielder XTR, which is again a composite core wire, which has better handling and better tip retention. That means when you give a tip bend, the bend on the tip retains itself because of the acton content of the central core. And these are and lots have been said about these wires as well, so I won't go into that. But what is important in these new wires is this composite core where there is a rope, central acton rope, which actually allows tip retention and a linear torque of 1:1, avoiding whiplash and avoiding release of energy, which causes the dissections of these channels. And this is entirely from the Fielder XTR and the Sion family. They make the tip durable, they are less load, and there's no whip. Advancing the Corsair. So you got the wire into the collateral channel, you got the wire into the distal. The next thing is to advance your Corsair. And the Corsair is gently, with a firm, gentle pressure and a counterclockwise movement at the same time, advances. But many a times, you will see, as in this particular case here, the Corsair was stuck midway in the septum, and this is particularly true when you go into elderly people. There must be some amount of calcium and some amount of tortuosity which the Corsair cannot accomplish. And we've used a mini-track 1.2 balloon, not more than 3 atmospheres pressure over there, to dilate these channels. And then we had a crossing, a successful crossing of the Corsair, as you can see, and we set it up for, the next thing is to set it up. So once you have your Corsair going into the distal part of the occluded artery and you've got a wire in the distal part, in a planned retrograde approach, this is the time when you go antigradely and set up your antigrade wires and positions. Till this time, till you got an antigrade access, I generally don't go antigradely and put in wires, because those wires, while you're working retrogradely, if you can dissect the proximal part of the artery, you get into a lot of trouble. And so this is where you set up your this is time to set up your antigrade approach. And once you set up your antigrade approach, you start again with a microcatheter and a soft wire, get yourself to the lesion. And the question is now, connecting these two wires. In this particular case, you've got to be careful, because when you come to the distal tip, what one needs to avoid is picking up into an extraluminal spaces and putting these little wires into there, and you can have distal dissections, and then you just increase your stenting area and you end up metal jacketing the entire artery. So a little gentle caution at this time is cannot be emphasized more. Set up the Corsair at the distal and it's difficult to come back into the luminal spaces if you've got an extraluminal, and then it kind of, you have a portion of the stent that may be extraluminal but still okay. This is the most likely step to fail in the practice, and this is one of my 3 failures where we did an LAD, and this was a heavily calcified artery, and we just could not connect. This is after 4 hours of deliberating on this artery. We could get this far, this close, but we could not connect. And why did we not connect? If you all notice, there's a huge chunk of calcium belying the 2 wires, between the 2 wires, preventing our channels to meet. And this is exactly the situation. It's beautifully demonstrated by Kimura in this slide, and I had to borrow it to show you this case, that when you get these 2 wires, you could take a balloon and connect the 2 channels, getting a retrograde and antigrade channel there. But when you have a layer of calcium in between there, like this, no matter what you do to this channel, you're not going to be able to connect the 2 parts, because there's a calcium wall in between the 2 channels. In this situation, you can move a little distal or forward or proximal to see if you can get a non-calcified area to connect this, but this is a big challenge. And over here, we have to have the humility to come out and say, sorry, we failed and we cannot do it any further, because we could do great damage in trying to achieve success in these cases. The connection of these wires can be achieved by various techniques, and this has been discussed. You could have the cart, which is a retrograde wire into the once you have a retrograde wire going into the proximal lumen, you could actually put in a balloon here and expand it, and that is what we did many years ago with the cart. This can cause some kind of a spiral dissection in the distal part of the artery, which is actually the important part of the artery. And so to avoid this, most people have moved to a reverse cart, which means you get this wire in there, and we'll talk about it in the next few slides. Once you have a cart, once you've done a dilatation over the retrograde balloon, as I can see in this picture over here, it's simple to go ahead and get an antigrade wire accessing this system, and you can see an antigrade wire in the system, and then it becomes a simple angioplasty. You've got to make sure that when you have a distal RCA, you cannot be satisfied with having an antigrade access into just the PL or the PDA, and you should try to get access into both the main branches, because you do not want to exclude any of those big branches and have residual ischemia at the end of such a long procedure. This is the cart technique that we showed here. No, sorry, if it would move. The reverse cart. This is a case of an LAD that we had from the ostium, and what we did was, when we have the retrograde wire system coming into a false lumen, we have the antigrade wire going up, and the antigrade wire is within the CTO body. We find that when we have both these wires are satisfactorily close to each other, and these wires are not too far apart, and that's important to know. And that's when you can put in a balloon in the antigrade system and break open the tissue in between the 2 wires. And once you have that, you can see that the wire connects in, and the wire is then guided into the guiding catheter, trapped in the guiding catheter. The Corsair is advanced into this CTO, into the guiding catheter of the occluded artery. And it's simple then to proceed with that, you externalize this wire using an RG3 wire. So once the Corsair is in the guiding catheter of the occluded artery, you can exchange the wire for a 325 centimeter, 330 centimeter RG3 wire. And what most of us, it's very important over here that once you actually completed this, and then it's an angioplasty over a wire, and you can take an antegrade access, but it's important to exit and complete these procedures well. And it's important to make sure that once you put in stents, and if your stents have come into the ostium, before you lose wire position of the guiding catheter, don't get your guiding catheter to re-engage because the strut's outside. Get a diagnostic, visualize with the diagnostic, and then complete the procedure. The other thing is to make sure that keep an eye for thrombus in the donor arteries, and sometimes you can have the donor artery complicating with a thrombus over there and occluding. Make sure that you refrain making injections into right coronary arteries, particularly once you have an ostial aortic dissection. Over here, it's important to make sure you don't make antegrade injections. In fact, we have moved away from making antegrade injections at all, and we are completely IVUS guided now antegradely once we've got access. Also look for little straightening of the channels, and look for septal perforations and septal hematomas. These can be nasty and fatal. And it is important that if you have to dilate a channel, don't do it more than a 1.2 balloon, and don't go to more than 3 atmospheres of pressure. It's also important to exit making sure that you've got no perforations from wire perforations, and make sure that your distal bed is looked at properly with good distal angiographic assessment to make sure. Sometimes we take our microcatheters and inject through that to make sure there's no extravasation, because this is the time that if there is an extravasation, you could coil it before you get tamponade. Just to go back now to the second part of the lecture, which is a case example to kind of make this point, a male 67 presented with crescendo angina. In 2004, he had an anterior non-ST elevation myocardial infarction, triple vessel disease, underwent a CABG. 2008, he presented with cardiogenic shock, and that time his grafts had failed. An emergency PAMI was done to the right coronary artery and the circumflex with Cypher stents. 10 days later, the LAD CTO was attempted, but we failed in 2008. He was stable with angina and comfortable on medical management. He had unstable angina in 2009, and that time he had an instant restenosis of the right coronary artery, so we did a re-angioplasty to the right coronary artery using Zion stents this time. In 2012, he came back with unstable angina, and this is his angiogram, and this is 2 angioplasties later to the right coronary artery. We find that he's got an instant restenosis in the mid-RCA and in the distal, which fills up the entire left system here. The left system is a very short left main and an ostial occlusion of this at least 5 years that I know of, and probably from the time of surgery, which was from 2004. So this was almost around 9-year-old total occlusion that we're talking about. And to kind of plan this angioplasty, to set it up, it was important that we go ahead and fix the right coronary artery first. So we fixed the right coronary artery, and this was IVUS guided. We realized that the previous stents were underexpanded or undersized, so we moved up almost 0.5 millimeters in size of those stents, redid this right, and 7 days later got him back for the LAD. Now, once we set this up, it was important for us to know which channel to use. We had 2 over here, 1 here and 1 in the yellow. And we realized that if we use the yellow, which is more proximal, that's my favored approach. And so we took a Sion wire, and we had an access with a Corsair into this retrograde system. Once we had this, we take a tip injection to make sure that you have your orientation of the occluded artery distally, so that you can decide and change your wire positions over here if you need to. We decided to take this Sion wire and keep an access in this retrograde system, and you may want to escalate this wire to your Miracle or something if you have a harder distal cap. We didn't need to in that case. But whatever we tried to, we went to an Ultimate Brothers, but we found that we were going into a false lumen distally, and here, even though we had access, we weren't in the true lumen. And this can be judged with intravascular ultrasound, and we make sure that the wire comes into the guiding catheter, and we had difficulty. It is this time it was important to kind of set up this antegrade wire, a balloon to dilate the antegrade channel. And once you had that happening, it is then not difficult to retrogradely enter the channel that you create in the antegrade space. The retrograde wire enters it, and then you get that wire into the guiding catheter, follow the Corsair, you trap the retrograde wire for support, and then you enter the Corsair into the retrograde channel, change it for an RG3, and complete this angioplasty over the antegrade wire. Get an antegrade access with a good wire support, making sure that you coil your wires distally so that you avoid wire perforations in the event, and complete the procedure. And this is how the final result is in these procedures. A stress nuclear imaging on this particular gentleman is negative at 6 months of follow-up following this angioplasty. What I've learned is a failure is a man who has blundered but is not able to cash on the experience. So whatever we experience and whatever we go through, we have to improve upon it and make sure we don't repeat it. Thank you very much for this patient listening.
Dr. Kirti, I have one question. In your practice of CTO retrograde techniques, do you routinely use CT angiogram to evaluate the microchannels before you attempt the procedure?
No, and the answer is no, I do not do that routinely. But I do think that if you're looking at we fail in 3 cases. And so will the CT scan improve our success rates? The 3 cases we failed, we were able to get retrograde access. The problem was the calcium. So the fluoroscopy images sometimes give me enough information, and when there is calcium, sometimes on the CT scan, calcium is completely overrated. In that sense, you see a lot more calcium, and sometimes all that calcium you see in the CT scan is not going to tell you that you're not going to succeed in these cases.
No, I think your question is to whether CT scan helps in assessing the collaterals.
No, to plan the strategy, like if you see microchannels.
So only
Microchannel.
in an ostial RCA, where the takeoff can be unusual and you don't see a substantial part of the RCA, well, then you can have a CT scan to tell you what path this right is taking, whether it's taking a shepherd crook or whether it's a straight down descent. Besides that, I don't see...
No, to know whether the microchannel is connecting, that's what is your question.
But a CT scan does not help you do
I
that.
don't think
I mean, you can have the choice of wires also, no? When you have whether you need to use a drilling technique or a sliding technique.
You know, yes, to decide whether it can be open calcium in a native vessels, occluded vessel, is CT scan. But then I don't think it will give you idea about the microchannels. We have been doing CTOs for last 2 years. We have also done a lot of, I think we have failed in most of the cases in the beginning. Then gradually our success improved. But CT scan we have not been doing. You cannot see angiographically microchannels, but when you surf, you can still get, your catheter wear can still go. Even if angiographically you don't think there is, so surfing is very important. You should surf all the channels, microchannels, and sometimes some channels which are not visible in angiography, when you surf you will find that this is leading to your occluded artery. I think that's